Good afternoon, guys. I've got discussion A for you. Now, this discusses senior falls and prevention. It's the second series I'm gonna do on falls this week. So please sit back and enjoy. Earl Victors was accustomed to taking Molly, his shepherd boxer, something else mix for strolls on the beach or around his neighborhood in Seaside, California. A few years ago, though he started to experience problems staying upright. If another dog came toward us, every single time I'd end up on the ground, recalled Victors, 69, a retired electrical engineer. It seemed like I was falling every other month. It was kind of crazy. Most of those tumbles did no serious damage, though one time he fell backward and hit his head on a wall behind him. I don't think I had a concussion, but but it's not something I want to do every day, Victors said. Ruefully, another time, trying to break a fall, he broke two bones in his left hand. So in 2022, he told the oncologist who had been treating him for prostate cancer that he wanted to stop the cancer drug he had been taking off and on for 4 years. And Zolumade, sold as Xtandi. Among the drug's listed side effects are higher rates of falls and fractures among patients who took it compared with those given a placebo. His doctor agreed that he could discontinue the drug, and I haven't had a single fall since, Victors said. Public health experts have warned of the perils of falls for older people for decades. Folks. In 2023, the most recent year of data from the Centers for Disease Control and Prevention, more than 41,000 Americans over 65 died from falls, and an opinion article in JAMA Health Forum pointed out last month. More startling than that figure, though, was another statistic fall related. Mortality among older adults has been climbing sharply. The author Thomas Farley, an epidemiologist, reported that death rates from fall injuries among Americans over 65 had more than tripled over the past 30 years. Among those over 85, the cohort at highest risk death rates from falls jumped to 339 per 1,000 in 2023 from 92 per 100,000 in 1990. The culprit in his view is Americans' reliance on prescription drugs. Older adults are heavily medicated, increasingly so, and with drugs that are inappropriate for older people. Farley said in an interview, this didn't occur in Japan or Europe. Yet the same 30-year period saw a flurry of research and activity to try and reduce geriatric falls and their potentially devastating consequences, from hip fractures and brain bleeds to restricted mobility, persistent pain, and institutionalization. The American Geriatric Society adopted updated fall prevention guidelines. In 2011, the CDC unveiled a program called STEADY. In 2012, the United States Preventative Services Task Force recommended exercise or physical therapy for older adults at risk of falling in 2012 to 2018, and again last year. There have been studies and interventions and investments, and they haven't been particularly successful, said Devon Mast, a geriatric psychiatrist and researcher at University of Michigan. It's a bad problem that seems to be getting worse. But what are prescription drugs driving that increase? Geriatricians and others who research falls and prescribing practices question that conclusion. Farley, a former New York City health commissioner who teaches a Tulane University, acknowledged that many factors contribute to falls, including the physical impairments and deteriorating eyesight associated with advancing age, alcohol abuse, and tripping hazards in people's homes. But there's no reason to think of any there's no reason to think any of them have gotten 3 times worse in the past 30 years, he said, pointing to studies showing declines in other high income countries. The difference the difference, he believes, is Americans increasing use of medications like benzodiazepines, opioids, and antidepressants, and gabapentin that act on the central nervous system. The drugs that increase falls mortality are those that make you drowsy, dizzy, he said. Problematic drugs are numerous enough to have a acquired an acronym for FRIDS, or fall risk increasing drugs, a category that includes various cardiac medications and early antihistamines like Benadryl. Such medications play a major role in, agreed Thomas Gill, a geriatrician and epidemiologist at Yale University and a longtime falls researcher. But he said, there are alternatives. There are alternative explanations for the increase of death rates. He cites changes in reporting the causes of death. For instance, years ago, falls were considered natural consequences of aging. And no big deal, he said. Death certificates often attributed fatalities among older people to ailments like heart failure instead of falls, making fall mortality appear lower in the 1980s and 90s and 1990s. Today, over 85 cohort may also be failure and frailer and sicker than the oldest were 30 years ago. Gill added, because contemporary medicine can keep people alive longer. They're accumulating impairments more than drugs they take could make them more likely to die after a fall. Other skeptic Neil Anderson, a geriatrician and fall expert at the University of Michigan and VA Van Ann Arbor healthcare system, argued that most doctors have come to understand the dangers of FRIDS and prescribe them less often. Message delivered, he said, given the alarms sounded by opioids about benzodiazepines and related drugs, and especially about opioids and benzos together. A lot of primary care doctors have heard the gospel, he said. They know not to give older people Valium. Moreover, prescriptions for some fall related drugs have already declined or hit plateaus, as death rates uh, even as death rates because or falls falls have risen. Medicare data shows lower prescription opioid use um, less than a decade ago. For example, benzodiazepine prescriptions for older patients have slowed, must said. On the other hand, the use of antidepressants and gabapentin has increased. Whether or not medication use outweighs all other factors, nobody disputes that these agents are overused and inappropriately used and contribute to the troubling increase in death rates among seniors, Gill said. Thus, ongoing campaign for deprescribing, stopping the medications whose potential norms outweigh their benefits or reducing their dosage. We know a lot of these drugs can increase falls by 50 to 75% in older patients, said Michelle Sternman, a geriatrician at University of California, San Francisco, and co-director of the U.S. Deprescribing Research Network, established in 2019. It's easy to start meds, but it often takes a lot of time and effort to have patients stopping them, he said. Hurried. Doctors may pay less attention to drug regimens than to health issues that seem more pressing, and patients can be reluctant to give up pills that seem to help with pain, insomnia, reflux, and other common age related complaints. The Beers criteria, a directory of drugs often deemed inadversible for older adults, recently published recommendations for alternative medications and non-pharmacological treatments for frequent problems, cognitive behavioral therapy for sleeplessness, exercise, physical therapy, and psychological interventions for pain. It's a real tragedy when people have this life-threatening event. Sternman, co-chair of Beers panel, on alternatives said of falls. He urged older patients to raise the issue of FRIDS themselves if their doctors haven't. Ask, do any of my medications increase the risk of falls? Is there an alternative treatment? He suggested being an informed patient or caregiver can put this on the agenda, otherwise it might not come up. The New Old Age is produced through a partnership with the New York Times. KFF Health News is a national newsroom that produces in-depth journalism about health issues and is one of the core operating programs at KFF. An independent source of health policy, research, polling, and journalism. Learn more about KFF. The article first appeared on KFF Health News and is published here under a Creative Commons attribution, no diversities, 4.0 international license. Online bonus content. This has not been peer viewed. The views and opinions expressed here are those of the author and do not necessarily reflect the opinions or recommendations of the American Nurses Association, the editorial advisory board members, or the publisher, editors, and staff of American Nurses Journal. Okay, guys, so that is A for you. I will be back on with B shortly. Give me a bit for B, please, and I'll be back on with you. Okay? For now, Gator Wellness, take care, folks.